Robin, thank you for the introduction and asking me to talk on this topic. Uh, Unfortunately, I'm back in the US right now, but doing this recording from my time here in Dulacal, and just wanted to extend such a warm thank you and appreciation for the group and all of the time that we spent during this trip and the great collaboration. So, without much more discussion, uh, my topic here is really to look at a global perspective of diabetic foot syndrome. I'll be online live, so I'll see what the other presentations and their materials are. But clearly, the purpose of this talk is not to look at causes and treatments and some of the outcomes, but really to see what the global perspective is on diabetic foot syndrome, because this clearly is impacted differently in different regions and different countries across the continents. But there are some similar themes that can look at public health implications, as well as how this can affect general populations and even the overall productivity economy of a country in areas of high diabetes or poor sugar controls. So I have no disclosures other than the fact that this is a lot of our practice in Milwaukee is seeing this come into the emergency room, normally right around end time of the day. So around 1700, 1800, this is when we get the call that a patient's been having redness, warmth, and has been feeling essentially flu-like symptoms for 1 to 3 days, and they have a advanced leukocytosis and are febrile in the emergency room, and this is what we're brought into. So one of the things to think about, and this is a different direction with this topic and with this specific lecture, is unlike the other talks, which are going to look at the immediate implications of poorly treated diabetic foot ulcers. So amputation, osteomyelitis, persistent wounds, time in hospital, admissions, non-weight bearing status, physical therapy, recovery, and the things that come with that, and obviously time off of work. This is all important, but one of the things that's really important when you look at a global perspective on diabetic foot syndrome is that it represents an independent risk factor of morbidity in diabetic patients as compared to diabetic patients without ulceration. And patients with ulcer actually have about a twice mortality rate due to cardiovascular disease that a similar cohort, a diabetic patient without ulceration, does not have. So, as the WHO states, and we all know from our practices, is these ulcerations of the foot and ankle, they're associated with neuropathy. So patients have issues with poor fitting shoes, they need orthotics, they have neurotrophic wounds that they don't feel, they have foreign body events where they'll step on a nail or a piece of glass, and then these wounds fester and persist. With that break in the skin, they then develop osteomyelitis. They have some level of ischemia, even if it's just microvascular. And in the US annually, this results in about 80,000 amputations, with almost 80% of them related to diabetic foot ulcers. So it's great to look at slides on these issues and increases in morbidity and mortality, but this is really the reality of what we're seeing in the emergency. Primarily, these are patients who are poorly compliant, a lot of times with medical follow-up and with appropriate medical therapy. They don't have primary care physicians. They may have poor foot care and then just overall poor hygiene. And here's what we're seeing. So in image A here, you see essentially a modified ray amputation. On this far right image, you see really extensive changes to the foot with underlying necrosis. So what is the big deal? So aside for the immediate morbidity of the amputation, the recovery, time to prosthetics, and we'll talk about this in just a little bit. There's really an enormous cost to the overall system. There's loss of income. This impacts the patient's entire family. For patients that are the income earners, the primary income earners for their household, this can really be devastating, and that plays into a lot of the other compliance issues that we have with follow-up. So even if after amputation, I've had patients that try to get back to work ahead of prosthetic use, or once they get their prosthetic, they're immediately on it, returning to 12 hours of rigorous manual activity, and then that can just really be a bad marker of worse outcomes in these types of patients. So this is just a enormously eye-opening slide here about other associated conditions. So you look at patients with diabetic foot syndrome versus patients without diabetic foot syndrome. Coronary disease is significantly increased, as you can see here. Percentage of TIA in this patient cohort is almost double. The percentage of stroke, once again, almost double. Once again, as we quickly move through some of these associated comorbidities, the risk of angina, myocardial infarction, TIA, overall death, stroke is all significantly increased when we look at the associated p-values for the study presented here. And it's something that we really do need to remember is not just dealing with the patient in the immediate period, but it's managing these comorbidities through amputation, through recovery, through additional procedures, but also realizing that these morbidities are going to have a significant impact on overall longevity and recovery for the patients in general. So you're balancing multiple problems here. It's not just an isolated foot. Normally these patients are coming with significant major cardiovascular disease that has to be managed. It may limit their overall life expectancy or lead to other postoperative complications that really impact your care. So what are the primary causes of death in these patients? No, it's not stroke. It's not limb loss. Normally these patients will recover from amputation. It's not limb ischemia. A lot of times there's no macrovascular disease. It's all microvascular pedal loop issues. It's not pneumonia. It's coronary artery disease. So the amount of times, certainly in my practice, that you successfully manage a patient through significant comorbidities, you get them to amputation. Maybe you had to do a guillotine amputation, then formalize them. And then, in that 3 to 5 day period after surgery, they really start to have significant coronary issues. They have a non-ST elevation MI, and now you're dealing with a patient with recent amputation that you're heparinizing or considering performing a percutaneous coronary intervention, or they have a decreased ejection fraction now, and you're managing this on a patient that needs to be as fit as possible to have a quick recovery to prosthetic use. So when we look closer at the biochemistry behind some of these increased comorbidities and cardiovascular mortality, it really becomes much more clear when you look at this slide. Elevated levels of inflammatory markers such as CRP being almost double in patients with diabetic foot syndrome, total cholesterol and LDL being higher in their cohort counterparts without foot complications, and then even some of the lesser known markers such as adiponectin, which is reduced in type 2 diabetics and related to low HDL, as well as high serum level markers of inflammation such as TNF-alpha and interleukin. Resistin is a marker of adipose and counters the effects of insulin, as you can tell here. It's significantly elevated in patients who suffer from diabetic foot syndrome. So now this all comes together as we have patients who are really poorly situated to be recovering from major amputation. They're at risk from extended lengths of general anesthesia. They suffer from wound complications and prolonged recovery to prosthetic use. So these may not be the patients who undergo early prosthetic use. And so it becomes a compounding factor. Diabetes is certainly the main cause of non-traumatic amputation of lower limbs in the world. Infection in diabetic foot syndrome increases the risk of amputation by about 50% compared to diabetics without ulcers. And what increases this risk? Well, everybody does this in practice, knows this is pretty straightforward. Ulceration duration greater than 30 days, because clearly the risk of osteomyelitis or conversion of the wound from being dry to infected goes up. History of recurrent foot ulcerations, traumatic causes, vascular disease, and neuropathy. So as we can tell, significant impacts on the patient, their household, their family, their quality of life, their ability to work. But the topic of this talk is global perspectives and the impact this can have at a much higher level when we look at economy, GDP, overall workforce. There are significant healthcare costs on insurers, on healthcare systems, hospitals, rehabilitation. It's just a compounding factor. Here we can see a patient with a prosthetic out of Jaipur. The Remotion knee has a cost of less than $2,000 US compared to alternative Western prosthetics being almost 40 times that. And now we're starting to see on this slide how our expectations with prosthetic use can be greatly impacted by the other patients' comorbidities here. So cellulitis, wound breakdown, patients with high A1Cs, anybody that is having significant cardiovascular events around the time of surgery or early rehab, we're going to see delays in all of these things, and ultimately that's going to impact recovery and return to normal function and quality of life. So unlike all of the prior presentations, this really isn't looking at the specifics of how to treat diabetic foot syndrome, either surgically or medical, wound care, treatment for osteomyelitis, and what are the best options. It's really reiterating that it is a marker to watch for because of significant other complications. The need for risk factor modification, aggressive medical management, really getting these people plugged into an appropriate program, and close eyes. We discussed this just this past week at the dialysis workshop, that the more eyes the better, and this is certainly one of those conditions where that's true. So ulcer treatment to prevent amputation is a goal, but clearly overall medical optimization in general is the goal as well. So diabetic foot syndrome, it can be difficult to treat, to prevent major morbidity, disability, cost, and effect on economies and communities, but it itself is an independent marker of other comorbid conditions to be aggressive about treatment and management so we can get the outcomes that we require for these patients. Thank you very much.